right, so good to be here, and I will try to keep you awake, if not like mildly entertained. So I have no financial disclosures, and I do acknowledge that I've ripped off about just every available slide set out there on allergic rhinitis and sinusitis. There's not one slide in here that is of my doing. Almost, maybe there's one or two. But you know, the good news is that there's plenty of stuff out there, and it was actually fairly easy to synthesize this. It did take a little time, but mostly the World Allergy Organization contributed a lot of slides. Mark Dykowitz, who's at Wake Forest, I used some of his stuff. Very nice guy, so I know he doesn't mind. All right, so let's talk about some definition of rhinitis and allergic rhinitis. And so this is stuff that you should be familiar with already, you know, for most of you folks. And by the way, just before I get much further, show of hands. Sub-I's, PGY1s, PGY2s, PGY3s, okay, and am I missing anybody? Yeah, well, thanks, Jerry. All right, so good to know who's in the crowd. All right, so rhinitis, it's, as you can, as we're all familiar with, you know, the general symptoms include nasal discharge, sneezing, airway obstruction, itchiness in terms of the hallmark signs, the physical findings. Allergic rhinitis, you know, basically means that it's an IgE-mediated mechanism with inflammation, airway hyperreactivity some ways, and also mucosal thickening and remodeling. We're all familiar, we are all have heard about allergic rhinitis, but also there's various other forms as well too that are very common that we see in our ambulatory practice. That includes infectious rhinitis that happens quite often, especially this time of the year with, say, the kids coming back to school or college kids coming back to school and infecting each other. Non-allergic, non-infectious rhinitis, which is one of the most common diagnoses that we make in the allergy space when people send patients to us and we find out that there's not a relevant allergen. Nares, which is kind of like non-allergic rhinitis. It does have eosinophilias, but they have no evidence of atopy otherwise. And then chronic rhinosinusitis, which we'll talk about a little bit later on. There are also some very minor, you know, rare things like I call lifestyle rhinitis, where you can have rhinitis to foods, sex, drugs, alcohol, that type of stuff. So, you know, that's a little less common, but you hear about it. All right, so the prevalence of rhinitis in the United States is about 30%. About a third of that is seasonal. Let me see if I can get my mouse to go here. Oh yeah, there you go. Very cool. So third of it's seasonal. About 2/3 of it is perennial. And you can see that overall, if you averaged it, about 65% of them will have positive skin tests. And you're going to have more of that if they come in with a history of seasonal versus, say, history of perennial. Why do we care about allergic rhinitis? You may think, well, this is just really a minor disorder, you know, who cares, right? Turns out, well, you know, we do care because it's so common. It can impair quality of life. It can lead to issues in terms of work and school absence, impaired learning, sleep, and also it has lots of comorbidities, so it can be sometimes the canary in the coal mine. So I want to ask you guys a question. Given a list of conditions including asthma, respiratory infections, stress, and migraine, where would allergic rhinitis rank in terms of mean productivity loss employee per year? So this is kind of a loss to society. So think about it, and I'm going to start it right now, and I'm going to give you guys 10 seconds to register. So I see 8, 9, 10. Let's see how many of you guys are out there. It looks like about a dozen and a half of you guys. So some of you guys may still be thinking. Go ahead and just guess if you can't come up with anything. All right, looks like we're not going to get any more. I'll stop it. Get rid of this little pop-up. Display the the results. And we have a spread. It looks like you guys are voting for second. But we have a spread across the continuum here. So it actually turns out to be number 1. So in a study that was done about six years ago, it's kind of like a socioeconomic policy study, they found allergic rhinitis, had a mean loss of productivity of about $600 per employee per year. And you can see that it towers literally among some of the other common disorders that we commonly think of when patients come in and say, I can't go to work today, such as, say, an upper respiratory infection, maybe an asthma exacerbation, anxiety, even migraine headaches. So quite impressive. We know that allergic rhinitis also impacts quality of life. So if you look at this, you can see that, oops, let me see if I can back up here. You can see that it impacts physical functioning. So the light blue bar is controls. Allergic rhinitis is the orange bar. Lower the score, worse the healthcare status. And so you get lower physical functioning, physical ability, body pain, general health, vitality, and mental health. And again, as I mentioned earlier, there are comorbidities that are associated with allergic rhinitis. And we'll talk about a few right here. Mostly, we'll talk about chronic rhinosinusitis and acute rhinosinusitis in a little bit. But the other thing that we want to think about is that when we think about allergic rhinitis, we also have to keep in mind the possibility of asthma, especially in this region of the country. So overall, if you have asthma, 85% of you will also have allergic rhinitis. If you have allergic rhinitis, approximately 50% of you will also have concomitant asthma. So that's basically the takeaway point of this diagram right here. All right, and this was a study that was done at Brown University in Providence, Rhode Island by Sedipane. This is a classic study where he enrolled all the incoming freshmen, assessed them for allergic rhinitis by skin testing and symptoms, and followed them out over 23 years and found that they had a threefold increased risk of new onset asthma if at baseline they had allergic rhinitis coming in versus non-allergic rhinitis. So again, we'll talk about this a little bit later, but always keep asthma in mind. Look for the signs, look for the symptoms, and pursue the diagnosis if necessary, especially in your younger patients. Now, we all know that allergic rhinitis is tied to a number of very common allergens that we see around here. Obviously, house dust mite, grass trees like birch tree, Bet V1, oak tree, maple trees, ragweed pollen, short ragweed is starting to spike already. We also have moderate amounts of mold in the environment, like Cladosporium, Aspergillus alternaria, which is associated with both rhinitis and also asthma. Pets, dogs, cats, cockroach, Blagi 1 German cockroach, indoors, and we've just talked about molds already. So what happens when you have an allergen exposure and in the nasal passage, and how does it work? So you may be familiar with this already, but it's worth going through again. You have cross-linking the allergen with IgE, cross-linking the IgE on a mast cell, release a number of mediators, preformed mediators like histamine, prostaglandins, prostacyclins, leukotrienes, and so forth, and it sets off an immediate early response, which we classically see within minutes, 15, 20 minutes, sneezing, itchy nose, runny nose, nasal obstruction, and conjunctivitis. But then it also causes endothelial cell activation and leukocyte chemotaxis and infiltration with eosinophils, basophils, T cells, if I can get this thing going here. And then you get a late phase response that occurs 6 to 12 hours later, where you get more nasal obstruction, rhinorrhea, and then you get this nasal hyperresponse, which is kind of what we often call priming. So once you are already primed, it doesn't take that much to set you off to have even further symptoms, and as well as higher sensitivity to non-allergic irritants like tobacco smoke, barometric pressure changes, and so forth. All right, so in terms of the history, what are you looking for? Okay, so you're typically going to be asking about things like, nasal symptoms like rhinorrhea, nasal congestion, sneezing, itchiness, which, kind of helps you lead you down the path of whether this is, say, non-allergic versus allergic. So itchiness is more common with allergic rhinitis. Also, itchy, watery, red, swollen eyes tend to be more common with allergic rhinitis, and more common with pollen allergies as opposed to dust mite allergies, where you may have more rhinitis nasal symptoms. You want to think about the season, okay? So is this early spring, late spring, summer, fall? If it's early spring trees, late spring grasses, we tend to get a break in the summer when the grass pollens drop and before the ragweed starts in about the second week of August. And then August to the first frost, we have ragweed. So what is the pattern? Year-round, well, maybe they have something indoors like molds, pests, dust mites, and so forth. Environment, what's going on at work, or does their workplace have problems with mold and so forth? So they may have perennial symptoms. Maybe they work in a basement someplace, and they notice that when they go away on vacation, their symptoms get better. Whether they're indoors and outdoors, again, so outdoor pollens, outdoor molds, for example, and again, specific triggers that may be that they may have in their environment. So they may have an indoor dog, indoor cat, or when they visit a family member that have dogs and cats. We talked about molds in buildings, but also mold when you cut the grass. So we often commonly think of pollen allergy or grass allergy when anybody cuts the mold, but you're also disturbing the dirt and so forth, and you're throwing up a lot of mold as well too, especially in the summertime when you have high humidity. We talked about tobacco smoke. Other things we talked about like food, spicy foods, and then other things including medications. Aspirin, NSAIDs, we think about the classic Santer's triad of polyps, asthma, and aspirin sensitivity. And also ACE inhibitors, we classically think about that as the ACE cough, but that could also cause rhinitis, as well as other medications, including beta blockers. Allergic rhinitis classification. When you talk to allergists or when you talk to other folks, we classically think about them as seasonal or perennial allergic rhinitis. In fact, when the phase 3 trials are typically done for approval of, say, a new antihistamine or a nasal steroid, that's typically what's in the FDA filings and so forth. But there's been a push over the past year. This is more of an international stuff. This is more of, an international effort from the World Health Organization through an initiative called ARIA, Allergic Rhinitis and Asthma, where they kind of try to classify almost a little bit like asthma, where you can have intermittent versus persistent, and you have mild versus moderate severe. So you could have intermittent moderate severe symptoms, or intermittent mild symptom, or persistent mild symptom, depending on the frequency of symptoms, more or less than 4 days per week, and whether you're having any type of disturbances in sleep, your daily activities, work and school, and the severity of the actual symptoms themselves. All right. We also want to find out how they did with previous medications, previous experience with over-the-counter medications, including including the adrenergic blockers like the oxymetazones and so forth. And we talked about comorbidities, and then atopy as well too. The rule of thumb is that if you have one parent with a history of atopic disease, then the child has about a 25% chance of atopic disease. And if both parents have atopic disease, asthma, allergic rhinitis, allergic asthma, atopic dermatitis, then about 50% of the children will have some sort of atopic disease at some time in their life. Physical exam. You're looking at the nose, you're looking at the nasal septums, you want to find out whether the congestion is on one side, does it go from one side to the other, or is it always on the right side? So that tends to argue for some sort of physical obstruction or a fixed physical obstruction. You look at the nasal turbinates, is it pale, is it bluish, is it boggy, the mucosa red, and is there any purulence to the nasal secretions? And then also you're looking for nasal polyps, so you're looking for this glistening white type polypy tissue. On physical exam, you're looking, you also palpate the sinuses for tenderness. Some people try to do transillumination, but that has variable yield in terms of specificity, sensitivity. And then of course you're looking at the eyes and the ears. You're looking for, again, the concomitant conjunctivitis symptom that often happens with pollen allergies. And then, as we mentioned a little bit earlier, a quick check of the lungs. All right, and then diagnostic testing. When we get to that, this is something that that you normally wouldn't do, but you would refer out for if you're definitely suspecting that there's issues with allergies and they're not responding to just your typical prescription medications. So we do percutaneous scratch tests and intradermal testing. So percutaneous is a kind of has more specificity. Intradermal testing has more sensitivity. But again, when you're doing this type of testing, you still need to take it back to the clinical presentation. You still need to match up the allergy skin test results with the clinical presentation. You can have present IgE, but that's not clinically relevant. Same thing goes for the in vitro IgE assays, that we casually refer to as RAS. So, but immunocap is probably the most common one that's used. That's typically used by research centers. There's other ones like Immunolite. The newest generation high-core RAS generally, I think, also fit in this category. Some of the older RAS may not have the right sensitivity, or the right predictive curve. So just be aware. So at least at U of L, you're always safe if you use immunocap, Phadia immunocap. Okay. Skin testing. So here's an example of skin testing. So we mark the spots on their arms or their back. So the volar region of the forearm or the upper back, and you place a drop of the allergen. You can use any number of devices. It looks like you could do a smallpox needle or these tines that have tiny little forks with the plastic ones. You do a simple scratch, you rock it. You're just breaking the surface of the skin, and then within 15 minutes you're looking for a wheal and flare reaction. And we usually document that either by the actual orthogonal. Whoa, cool. I guess they're trying to reboot there. You're measuring the orthogonal cross-axis of the wheal and flare, and you're taking the average of the two. Or in some cases, you're using a plus grading system, 1+, 2+, 3+, 4+. There's a move towards actually using more of the measurement because at least it's universally translatable. In terms of allergic rhinitis management, let's see how we're doing on time here because I want to make sure I keep time here for Dr. Lee here. There are three major things that we look at when we try to control allergic rhinitis. One is environmental control. Two is medications, which obviously you're very familiar with and you do all the time. And then number three, allergy immunotherapy when environmental control medications may be insufficient or not satisfactory. So let's talk about environmental control. All right. So again, it depends. And again, this is kind of where you would be able to do this if you have specific IgE results, either from skin testing or from in vitro blood assays. So for things like mold allergies, typical control measures, including keeping the place dry, using a dilute bleach solution to remove molds. Cockroaches, obviously trying to get rid of the sources for cockroaches, like getting rid of open food, making sure there aren't areas where they can get in, using insecticides and pest control where necessary. Pollen remaining indoor during peak pollen times. And we can get the information from the National Allergy Bureau, from the American Academy of Asthma, Allergy, and Immunology, or pollen.com, or some of these other websites. Using air conditioning where possible. And if you're doing yard work or so forth, that if you're done for the day, you should take a shower so that you're not, shedding the pollen inside the house. For pets, ideally, you have to get them out of the bedroom, even better from the entire house if possible, and vacuuming where they are to remove the pet dander, and washing the pets regularly. That can, of course, either getting, the advice for that type of stuff can get very volatile for both the patients and the pets, and you want to get rid of the cat, you might get a reaction like this. All right, moving on. So dust mite allergy avoidance is another thing that we do as well too. And by the way, the evidence for this is kind of mixed. So I'm not, you see a lot of stuff, you see a lot of measures here, but if you look at the actual literature and you look at the strength of the evidence, I would have to say that some of this is mixed, but but generally these things are low cost, low risk intervention. So it's something that we still feel that is worthwhile trying for, especially for patients that are suffering. So for dust mites, you want to keep the room dry, generally less than 50% relative humidity in the summertime. High humidity allows the dust mites to grow. Let me see if I can back up here. All right, great. And you want to wash the bedding regularly because that's where you're going to find them. They're going to be your bedding, they're going to be your carpeting, they're going to be your draperies. So you wash the bedding in hot water once a week to kill the dust mites. You use allergy-proof encasements. The fabric ones are more comfortable than obviously than the vinyl ones. The vinyl ones feels like sleeping on a garbage bag. So I usually try to steer away the patients from that. Vacuum cleaner with a HEPA filter and a HEPA filter in a central furnace as well too. So whenever the particles are disturbed, they will get picked up. removing carpets and pets and so forth if possible and infeasible in the environment. So those are some of the things to keep in mind. In terms of the management, this goes back to the classification that I shared with you a little bit earlier. So the ARIA guidelines. Again, this came out of the World Health Organization in 2001, was revised in 2008, and as you can see, there is a bit of a stepwise treatment, set of recommendations, similar to what you might see in the management of asthma as well too. So these are all familiar players to you, like nasal steroids, antihistamines, nasal decongestants or oral decongestants, LTRA antagonists, allergy avoidance, and immunotherapy. When symptoms become more severe, or medical management and avoidance is not working. This chart simply outlines, the full array of things that you can throw at this. So the full armamentarium, and I realize that we don't have time to go through this, but I understand that this talk is being recorded, so you can take a look at this later. So this chart simply outlines, what type of symptoms that they can control, onset of action and duration. So for our first line stuff, we typically think about nasal steroids, oral antihistamines, and this is their duration. But there are other things like oral decongestion, nasal ipratropium for rhinorrhea, mescopolamine for postnasal drainage, nasal chromines, capsaicins we'll talk about in just a little bit. So there's a whole series of things out there that you can use in addition to the traditional stuff that has been tried and true. So nasal steroids, we know this to be effective, and all guidelines use this as the first line of therapy for any type of persistent allergic and even non-allergic rhinitis. It works by 3 very different mechanisms to reduce total nasal symptom scores. So it reduces mucosal inflammation, so that slows down that late phase reaction that we talked about a little bit earlier. It reduces the mast cells, so that the next time that there is exposure to acute allergens, you have less, release of histamines, leukotrienes, prostacyclin, prostaglandins, etc. And then also you reduce vasodilatation, vascular leak, and you reduce glandular hypertrophy in the nasal passage. In terms of onset of action, most people will quote you that you're going to get, main effects probably within 12 hours, but you can see some effects in a couple of hours. Once it gets in there and binds the glucocorticoid receptor. This slide just basically show you that for the most part nasal steroids are fairly equivalent. So this is data comparing fluticasone propionate, which is very commonly used, as well as mometasone. All right, and you can see that they have pretty similar improvement in total nasal symptom scores, over a long period of time, and that can be sustained. So, question for you guys: 30-year-old pregnant woman with allergic rhinitis needs a nasal spray. What would you recommend? So I am going to start, and I want to see what you guys think. So I've got about 6 folks. Let's see if we can get you guys up to 10. I know there's more than 10 people in here. Take a gander. Come on. Okay. All right, good. All right, so there's something called, I didn't talk about this earlier, but there's something called absenteeism, which is you're not there. That's part of that whole work production. And then there's something called presenteeism, which is you're there, but you're not really there. So I suspect we may have a little presenteeism in here in the room right now. So anyway, I see that the majority of you folks have gone with fluticasone propionate, By the way, not to be confused with fluticasone furoate, which goes by Veramis. The fluticasone propionate is, the tried and true Flonase. So the answer actually is A. Budesonide is class B in terms of pregnancy safety. So, and by the way, same thing when we talk about, asthma medications, in terms of an asthma controller, budesonide, pulmicort is class B. All the other nasal steroids are class C. That being said, I would not fault you for using fluticasone. It's been out there forever. If a patient comes to me and said, I love my fluticasone, I wouldn't, and they don't want to switch, I would not fight them because the chances of anything happening are pretty low. All right, so I'm going to hide this and move on. All right, let's talk about antihistamines. So a good antihistamine should, mostly work on these types of symptoms: sneezing, rhinorrhea, itchy nose, itchy watery eyes, and maybe to some extent congestion, but that's where you're going to be mostly depending on your nasal decongestion, your nasal steroids. This happened to be a study with levocetirizine. Now, just like nasal steroids, for the most part, the newer second generation, third generation antihistamines, we're talking about fexofenadine, cetirizine, levocetirizine, desloratadine, those tend to be fairly equivalent in terms of total nasal symptom scores, versus placebo. So, again, my own personal bias is I love generic cetirizine. I send all my patients to Sam's Club and get the 1-year supply for $17. I do it all the time. Before I consider, say, something that might be a little more out of pocket for them, especially in this day and age. Nasal antihistamines, we hear about nasal Astelin, olopatadine, and so forth. And how do they compare? It turns out that nasal steroids still are going to be superior in terms of total nasal symptom scores. This was a meta-analysis that was published several years ago, and it looked at these standardized mean differences. So they standardized these studies that were going head-to-head between a nasal steroid and a nasal antihistamine. Anything to the left of this vertical line favors nasal steroids. As you can see, most of the studies trend that way or completely cross in terms of the confidence interval. And then when you get the summative score, the confidence interval is to the left of 0. That being said, there is growing evidence that adding, for your patients who have severe allergic rhinitis with severe congestion, that adding a nasal antihistamine is more effective than the two agents by themselves. And so this was a study published. There's several studies, but this was published 3 years ago. And you can see that unfortunately we don't have a placebo arm, which they should have had. But they have fluticasone by itself. You have azolastine by itself, and then they added the two together, and you can see the change that was better. That was significantly better than either azolastine or fluticasone. So we sometimes do this. So a typical regimen may be 2 sprays of fluticasone in the AM, each nostril, and then 2 sprays of azolastine in the evening. Azolastine can be dosed at either BID or QD, especially with the newer azolastine preparation. We sometimes call this as steroid. So that's kind of keep it in mind. All right, finally, something about capsaicin. So this is the stuff that's in, peppers and stuff like that. And Leonard Bernstein, Jerry's boss at Cincinnati, recently did a study that was just published and turning some heads, or at least turning some noses here, where they found that intranasal capsaicin in the nasal spray can improve total nasal symptom scores, especially in the areas of nasal congestion, sinus pressure, and sinus pain, versus placebo. This has been around for a while. It works by binding to something called the TRP valenoid 1 ion channel, or basically the capsaicin receptor, so that's easier to remember. And it works on the parasympathetic system, so it works on the afferent sensory nerves to basically desensitize it, and therefore, knock down your non-allergic rhinitis, so what we sometimes call vasomotor rhinitis, okay? So that's something that you might be aware of. This particular product is marketed as something called Sinus Buster. Is it available around here?
Over the counter.
Over the counter. Is it in Kentucky? I've not actually used it yet, but. Okay. I mean, I know it's in Cincinnati. Okay. Okay, great. So I've got about 15 minutes for rhinosinusitis. I want to kind of keep us on track here. And so Jerry Lee can do his talk here. So we talk about acute sinusitis. I like to call it rhinosinusitis because technically, if you're going to have sinusitis, you're going to have rhinitis symptoms involved. And so generally, that's the term that we tend to favor a little bit. This basically just tells you that there's a lot of acute sinusitis, and so you already knew that. So in terms of the underlying causes, you're probably aware of many of these underlying causes. We've already talked about atopy as a major cause of acute rhinosinusitis, also infection, structural issues like a deviated nasal septum, hypertrophic turbinates, and then other issues as well too, underlying diseases, cystic fibrosis, Schurz-Strauss, Wegener's, some of the stuff that'll show up on your internal medicine boards. And then things like rhinitis medicamentosa when they're trying to deal with their own allergic rhinitis or non-allergic rhinitis, as the case may be. Sinus anatomy, you're probably, again, familiar with this when you go down the x-ray, but again, it's worth reviewing for those of you guys if you haven't spent a lot of time looking at sinus film. Anterior to posterior in the coronal view, you'll see more of the frontal sinus up front. As you get towards the middle, you'll see the maxillary sinus. This is the ethmoid bulla. And then you're seeing this is a frontal sinus recess that would go anteriorly. And by the way, this is the right side of the face, and this is the left side of the face when you're seeing it, looking at a traditional sinus CT scan. You got your inferior terminus, your medial terminus, your middle meatus right here. And this right here is the all-important osteomedial complex that the radiologist often talks about. This is where you have the ostia for the maxillary sinus in the middle meatus. And it also, like I said, also flows into the frontal sinus as well too. If you go further back, you're going to go from the ethmoid sinus, you're going to start picking up the mesoid sinus more posterior in the face, and then this is an axial view where you can get that top-down view. And again, this is an example where somebody who has basically pansinusitis, and you can see that their osteomedial complex is completely stuffed up. Middle turbinate, the ethmoid bulla right there, inferior turbinate, and so forth. And when you have recurrent infection, you reduce your ventilation, you reduce your drainage of the sinuses, you get chronic inflammation remodeling that can eventually lead to chronic rhinosinusitis. And in terms of how, the basic pathophysiology, these are almost commonly triggered by a common cold or a viral paramyxal virus, an influenza virus. So you typically start with some symptoms. The patient starts to get better, but then acutely or all of a sudden starts to get worse because then they have bacterial superinfection with the usual suspects that you all know about, and then you'll have increasing symptoms. And if it doesn't go away after 10 days, then your suspicion is very high for bacterial sinusitis versus, say, a viral rhinosinusitis. If it goes on or is repetitive beyond 12 weeks, then you're going to be looking at chronic rhinosinusitis, where you have more of an issue with chronic inflammation, remodeling, a T1 type, TH1 type reaction, where you're having more interferon gamma alpha, TGF beta, and so forth. So we said that viruses are often a cause of acute sinusitis, but how much? So I want to know what you guys think. So click in. Do you think it's 20%, 40%, 60%, or 80%? So let's see what you guys say. I'll leave it open for a couple more seconds here. Okay, great. So we got 10, 12 people. All right, so I'm going to stop this, stop that, display the results, and you guys are saying, yeah, I'm thinking 60%. Very close. The answer is actually 80%. So the vast majority of all cases of acute rhinosinusitis is virus-driven. So
There's no E's out. Give him credit.
oh, I'm sorry. Excuse me. Good catch. All right. You guys, I got to give you guys credit. Very good. You guys did very good. So 80%. So the vast majority is is caused by viruses. All right. Yeah, I was thinking should I put on an E answer this morning. I was like, well, I didn't want to give away. It's 100%. I was like, well, that would sound crazy. All right. So, we talked a little bit about the microbiology, and again, you're all familiar: strep pneumonia, H. flu, Moraxella, Catarrhalis are the big ones. If you're looking at a chronic rhinosinusitis picture, you're tending to think more of the like the anaerobes, some gram-negatives, fungi, which tends to be it can be acute, but it tends to be more of a chronic type issue. All right. About 15 years ago, there was a major rhinosinusitis task force that was organized to try to help define sinusitis, and so they came up with a categorization of major symptoms. Some use it, some don't. Of major symptoms and minor symptoms, you see the list here. And so, so to meet the definition for sinusitis, you have to have either 2 major symptoms or 1 major symptom and 2 minor symptoms. Just keep this in mind. But you're going to be, again, asking for all the symptoms in general when you try to put together your picture. Sinus imaging. Typically, in our ambulatory practice, for the most part, we're mostly only going to be using CT for the most part. It tends to be more sensitive, and some studies say more cost-effective than your usual sinus X-rays. But that being said, we generally don't do it until we're looking more at chronic sinusitis, and after we've tried to treat them on an extended course of antibiotics, or if we're worried about certain issues like severe eye pain, other issues, tooth pain. We're worried about some sort of acute obstructions or so forth. MRI is something we think about when we're chasing down possible fungal sinusitis, versus maybe a mass. All right, the typical conventional treatment strategy includes antibiotics, which we all think about, but we should also think about symptomatic treatment, including decongestants, pain medications, saline washing, nasal irrigation, topical or systemic steroids, and then in recurrent cases or acute ongoing cases, possible functional endoscopic sinus surgery in patients who are appropriate candidates. And so an algorithm could be something like this, where again, because you're pretty much thinking 4 out of 5 times, it's probably going to be viral, and if you're in a position to watch and wait, you treat it symptomatically with decongestants, NSAIDs, Tylenol, topical steroids, but if they're not improving, then you would consider an antibiotic. But if they have primary signs of bacterial infection, such as some of those major symptoms, or symptoms are not getting better, or you're getting unilateral sinus tenderness, tooth or facial pain, a fever, perioral swelling, then you automatically have to go to antibiotics, plus maybe other studies as well too. If unsuccessful, then you can think about surgical evaluation and a differential evaluation, i.e., am I really dealing with run-of-the-mill chronic sinusitis, or am I dealing with other things? And we'll talk about that. These are typical antibiotic classes that you're all well familiar with, and generally you're going to be reaching for something that will give you good coverage for the H-flu, strep pneumonia, mock Shirah. So that could be amoxicillin plus minus clavulanic acid. If you are still worried about beta-lactam resistance, you can obviously do high dose amoxicillin before you go to some of the other drugs, or you go to the amoxicillin clavulanic acid, or a second generation cephalosporin. And then obviously there are other choices, including clinizone, and then possibly adding on metronidazole or clindamycin if you are concerned about anaerobes and some gram-negatives. Now, again, if they are not responding to treatment, then you're obligated to think about other things as well too, and things that often pop up in differential. And again, depending on the patient, depending on the circumstances, and so forth, we tend to think about things like serious dysfunction, Cartageners, CF, maybe some of the autoimmune Wegener's, some immune defects. So Jerry will talk about that. Perhaps there's something going wrong with the medication, so NSAIDs, aspirin. So these are some of the other things that you might want to keep in mind. Fungal sinusitis. They've got really stringy, yucky, yellowish, snotty cast coming out. And then I'm going to wrap it up here a little bit with the typical approach for chronic rhinosinusitis, which again you tend to be very familiar with. I do favor using nasal decongestion for short bursts, anywhere from 3 to 7 days. Again, we want to avoid rhinitis medicamentosa. We want hydration. We always talk about considering a long course of antibiotics, but remember, it's very controversial. There's not. It is controversial whether infectious causes are truly the primary etiology driving chronic rhinosinusitis. We talked again about this chronic inflammatory process that's more of a Th1 neutrophilic driven interferon gamma type process, and so antibiotics isn't really going to address that. And then, of course, nasal irrigation and topical steroids are going to be your typical regimen. So when things get complicated or severe, you often will think about referrals. And so generally, people that you will refer to would be us or the otolaryngologist. Us if you are suspecting atopic disease especially, and if they have concomitant asthma in some cases. So therefore an environmental and allergen evaluation may be appropriate. If you see something on the CT that might be remediated by a procedure, then an otolaryngology referral would be appropriate as well too. And then there may be other folks that you get pulled in depending on what you're thinking and what you're pulling in. Just a quick word about who we are. We are a joint clinic that's supported by both the Department of Pediatrics and Medicine. I hold positions in both departments, and so will Jerry once all the paperwork is done. We have clinics every day except for Tuesdays. I know a number of residents actually rotate through. We're all on the 10th floor of the Gray Street building, and if you have a referral or something we can help you with, we'd love to be able to help you out. So with that, I will turn it over to Jerry. Thank you very much for your time.